The speaker is Dr. Adam Kamradt-Scott, who is Senior Lecturer in the Department of Government and International Affairs at the University of Sydney. Adam is also co-convener of the Global Health Working Group of the British International Studies Association, which is one of the co-organizers of the conference. And Adam will also be continuing on the theme set out by Jonathan, which is pandemic flu and evidence-based medicine. So Adam, over to you.
Thanks. And it actually segues nicely, although maybe John might take a different view. This is probably a little bit more of an umbrella look at some of the dynamics that's been going on in terms of global trends with pandemic preparedness policy. And I just wanted to have a couple of disclaimers, I guess, to start with. The first is I'm not a conspiracy theorist. I'm probably one of the furthest from it. I've worked in government in the Australian Office of National Security, and it's suffice to say that experience alone convinced me that conspiracy theories probably are just that. The other thing to say is that this research was funded by the European Research Council. That was a 4-year study that finished in December of 2012 that was looking at how different arguments, ideas and belief structures shaped global health policy over the last 20 years. And we looked at 4 different case studies and basically characterised 5 different types of key arguments. And this is one of the papers that's a finding of this. And you could consider this a little bit of self-promotion, blatant self-promotion, but I've got copies of the last paper that was published. The publisher sent me 50 copies of this thing, and rather than throw it in the bin, I figured I may as well bring along and maybe someone will get something out of it. So they're free there, feel free to take them, feel free not. They're not going back with me to Australia. Okay, but just to sort of give a quick overview, I guess, of the history of influenza governance arrangements, for those of you who aren't familiar with it. Basically, the Interim Commission of the World Health Organization in 1946, when it was set up, one of the first things that was actually it was asked to do was to set up a program to deal with the problem of influenza. At the end of World War II, there was still an expectation that a repeat of 1918 was going to occur. For a time, believe it or not now, we sort of laugh at it, but influenza was actually known as or seen to be a war disease in the aftermath of 1918. And so there was a lot of anxiety around this at the time towards the end of World War II, and various governments were undertaking a number of initiatives to try and do that. And so the World Influenza Centre was established in London in 1947. And the following year, when WHO was officially founded, they then set up the WHO Global Influenza Program. A couple of years later, in 1952, the Global Influenza Surveillance Network was founded, and over the next 60 years it's continued to grow in number to the point that, I'll just throw it up here, it's now currently 141 national influenza centres spread around the world, with 6 WHO collaborating centres or reference laboratories where all the samples that are collected internationally are sent to, and there's 2 in the United States, Japan, Australia, China, London. And it was renamed, the whole system was renamed the Global Influenza Surveillance and Response System in 2011 following the passage of the Pandemic Influenza Preparedness Framework. And it basically sort of changed the nature of that arrangement from what was largely a publicly funded program to more of a sort of a public-private partnership. So we've got a situation now where industry is much more closely engaged with it, and they pay for some of the costs of running the scheme. Importantly though, in terms of pharmaceuticals, what we can see is that pharmaceuticals have actually been very prominent within the management of pandemic flu right from the creation of the WHO program. In 1918, the belief at the time was that it was a bacteria. That was then basically debunked in 1933 with a study by Andrews, Smith and Laidlaw, several members of which then went on to senior advisory positions in WHO. But the virus experimentation then started to begin with vaccines, but it was largely initially led by military scientists. It was eventually picked up by civilian authorities and they continued to run with it, but the interesting thing was that in 1952, when the WHO program was set up, was that the view of the expert committee on influenza actually made the determination that vaccination was still, quote, an experimental procedure. Having said that then, though, what happened over the next 7 years was a whole bunch of clinical trials, and this was in particularly then aided or reinforced with the 1957 pandemic. And basically, as a consequence of that, the committee sort of was reformed and renamed, and in 1959 it met and concluded that basically vaccination was the way to go. This was the key way to protect people from this nasty disease. And so ever since then, what we've seen is that influenza has been referred to as the cornerstone of pandemic preparedness. The advent of antiviral medications in the 1960s then started to add to this pharmacological arsenal. But one of the interesting dynamics that occurred around this time, and it also sort of coincided with the change in global politics that was going on, was that around this period, basically, influenza got taken out of the focus of being a global problem, and it got firmly embedded into national programs. So we had an effective mechanism to deal with this. It was called vaccination. Now it was all about the responsibility of governments, basically, to have vaccination programs in place. And the consequence of this was, despite repeated warnings, the WHO program basically progressively got scaled back to the point when the 1997 outbreak of H5N1 occurred. WHO's staff, influenza-dedicated staff, had been reduced to one person in headquarters in Geneva. And effectively what we saw was WHO kind of got caught out. And the outbreak, it infected 18 people, it killed 6, but it created such global anxiety that many public health professionals have been warning that that we were overdue for a pandemic, and this then created a level of anxiety where a lot of money started flowing. And WHO picked up the baton, and in 1999 released its first pandemic preparedness guidelines, and they were subsequently revised and released again in 2005 and again in 2009 on the eve of the 2009 pandemic. One of the interesting developments that coincided around the same time of this was the emergence of the evidence-based medicine movement. It was a movement that emerged in the mid-1990s out of Canada, and it rapidly spread around the world and got embedded in medical training programs. And this then started to have an interesting impact on global influenza policy, not only influenza policy, but certainly one of the things that immediately happened was a whole lot of randomised controlled trials, whereby they were really focusing on the evidence again to verify the fact that these were the most effective means to deal with influenza. In the aftermath of SARS and 2003 and the reappearance of the H5N1 virus, we then ended up what I sort of referred to, I guess, as a little bit of a perfect storm, whereby the anxiety generated by the reappearance of the virus, combined with the focus on that was being really readily advanced by all the major governance institutions that vaccines and antivirals were the way to go, was that it created a pivotal point basically when demand really outstripped global supply, and we ended up with a situation where a whole lot of countries were entering into advanced purchase agreements to lock up supply so that they could get access to it to begin with. And that whole focus has basically had an impact. It then led to the crisis with Indonesia refusing to share virus samples, which then prompted the reformation of the global influenza surveillance network. The level of anxiety, though, also did generate some considerable benefits, and probably the main one out of this is that WHO saw a lot of investment coming in between that period. And between 2006 and 2010, they suggest that the global capacity doubled from 500 million doses to around 1 billion. But the problem still remains, as we heard, is that even with this massive uptake in global production capacity, there's still massive global shortfalls, not only in terms of length of time taken to produce them, but also just in terms of sheer numbers. And in this sense, evidence-based medicine has had an interesting impact that's combined with the securitization of the disease. And one of the aspects, I guess, that this research study really got into was the fact that evidence-based medicine, by its very nature, preferences pharmacological interventions, while de-emphasising non-pharmaceutical interventions. And the other thing that, another interesting dynamic at the same time, has been that other pharmacological interventions have received less attention. And I put these in there just to be a little bit provocative. Particularly statins and elderberry extract. Now, the study on elderberry extract was one that was conducted in Norway. The cohort was about 50 patients, fairly small. But the more interesting study is on statins. And basically, the whole focus around the clinical benefits, the focus of the neuraminidase inhibitors is, as John mentioned, is to reduce the severity of illness. And one of the more interesting studies that just got released last year, published in 2012, is a study by Vandermeer and colleagues that was basically a study of over 3,000 patients that basically indicated that in administering statins, you have the same clinical benefits as administering antivirals, and yet very little attention has been paid to this. And it's been suggested to me that, well, what really needs to happen is we need to do a lot more clinical trials if this is even going to possibly be of any benefit. The trials that have been conducted so far are insufficient yet to sort of prompt a change in policy. But the problem is that there's very little incentive in the current market system for pharmaceutical companies to actually initiate clinical trials. Why? Well, the statins, for example, are off patent, so they're mass-produced in a lot of low-income countries already, and there's very little incentive in that respect for pharmaceutical companies to go in and try and do experiments to actually really see the benefit from these. There's also some interesting research going on in terms of a universal vaccine. And there's conceivably, according to some of the scientists working on this, it's been suggested that we could see the development of a universal vaccine within the next 5 years. It will take a number of years after that to come to market, but nonetheless that this could be the panacea to influenza preparedness. But again, that even if this does occur, one of the problems and challenges will be is that we're not really going to, it's still not going to fully address the issues around access and affordability. And what that means then basically is that one of the major challenges that we've got is that there's not enough attention conceivably being given to the other types of interventions to try and deal with this. I don't advocate that evidence-based medicine is wrong. Please don't misunderstand me. I'm seeing some smirks already from that. But equally, one of the key issues, I guess, that I would suggest to you is that it does have a tendency to preference particular types of interventions while downplaying others. And this is probably, in pandemic flu work, this has been most clearly, there's a great quote by an Australian scientist actually where he refers to the fact that things like social distancing measures would be as useful in a pandemic as a garden hose in a forest fire. And meanwhile advocating that, well, the only way to deal with this is through vaccines and antivirals. And what I suggest basically is that while evidence-based medicine has a place and it's very appropriate, equally there needs to be a little bit of a rebalancing occurring and more focus being placed on trying to increase the evidence base for non-pharmaceutical interventions, which have received fairly little attention. In addition to that, some additional political pressure arguably needs to be put on pharmaceutical companies to at least investigate the possibility that other medications, other pharmaceuticals may actually provide some relief or some benefit. Statins is one example. I'm not saying that this is the way to go, but what I am suggesting is that we need to at least prompt or provoke some further studies to see whether or not the clinical benefits from this in terms of the reduction of severity of illnesses is comparable to antivirals, because conceivably that would have a major impact on global pandemic preparedness policy. The cost of a 7-day course of statins is 50 cents. Compared to something like a 7-day course of Tamiflu, which is considerably more. It's around like $10 US. And I'll leave it there. Thank you very much. I didn't even get a yellow card.
No, yes.